topic of this debate is an interesting one, to me at least. And that is there an advantage to trying new anti-epileptic drugs indefinitely in refractory patients? So this is something that we're faced with in the clinics all the time. People come in, they're still having seizures. Do we keep changing drugs? How often do we keep changing drugs? How often do we add? If somebody has refractory epilepsy starting at age 9 and is still seizing, are we subjecting that person to changes for the next 70 years of his or her life? How long do we move on for that? And there are reasons to think about doing it and not. So, obviously refractory epilepsy is associated with increased risks, as I have listed there: disability, injury, psychiatric illness, death, progressive cognitive impairment. And we want to try to ameliorate the condition. How much of that is due to the seizures versus how much of that is due to the epilepsy, of course, is a subject of debate, which may be discussed here, I hope. And really whether physicians should continue to treat or say enough is enough, leave things as they are. I give up. I fail. I cannot succeed. And are there times when we should accept failure, saying that continued trials of medication and adjustments are really not worthwhile, and that the risk may outweigh the benefit of continuing to try drugs? Or is there some advantage to be gained by seeking to continue to have benefit? And there's some data on either side, and since I'm the host, I'm not going to give the arguments. I'll just summarize a couple of key points. And one is that there is some data that suggests that addition of new treatments can help to refractory patients. So one of the very interesting studies that showed clear benefit was that a meta-analysis performed by Philippe Rivlin looking at SUDEP found that patients randomized to drug in anti-epileptic trials that were submitted to the FDA, as opposed to patients randomized to placebo, did better, that the risk of dying was much less. And these are people who had failed multiple drugs typically in these trials. Most trials where people were enrolled in investigational trials, people have had 6 or 7 or 8 or 10 different drugs. But Philippe seemed to suggest that even in such a situation, adding a new drug resulted in less death. I published a study in clobazam looking at the treatment of drop attacks, and again, it reduced seizures. I mean, it was added into kids with Lennox-Gastaut, kids with drop attacks who had very frequent seizures and had been on many different drugs. But we actually showed that during the course of that short trial of 3 months, there was a significant reduction in injuries in kids with drop attacks, and this is with less than 100 subjects total. It was a striking finding. So there are a little data that I would cite here saying that maybe adding drug could help. On the other hand, there's a large amount of data saying that most people don't experience significant seizure control, that the number of people who have sustained benefit is really rather small. And some patients have worsening of seizures as we add drugs. There are good studies showing that when you simplify therapy, a significant number of patients improve. You have side effects, you have other sorts of problems. There's the issue of teratogenicity in young women or women of childbearing age, even if they're not so young anymore. I don't know how many people in the room have prescribed a drug and someone had a serious allergic reaction, but it's happened to me. It's probably happened to many of us. And we all feel badly. This is the 12th drug. The first 11 didn't work, and now you have Stevens-Johnson. This can happen. So there are downsides as well. So how should we weigh the advantages and disadvantages, and what are the arguments in favor of doing so? So we have 2 speakers. I forget who they are. I think it's Eleanor Brody and Martin Ben-Menachem. Yes, so Eleanor Ben-Menachem and Martin Brody will be speaking on either side, with Professor Brody arguing in favor of continued treatment. Treat until they drop dead, I guess, would be your motto. And Eleanor is don't treat till they drop dead. And I will end with that. Thank you. We have to have a vote first. So all those in favor of continuing treatment, as long as the patient is refractory, still trying something new, please vote yes. And I guess all those who are not in favor of continuing treatment, vote no. And I guess of the 2 people who voted so far, we have a 50-50 split. We'll do that too. I'll do that too. So it looks like it is moving more and more in favor of people advocating treating until they drop. And I am biasing the answers in favor of not doing that. So that tells you how strongly people feel about it. Okay, so we're at 85-15. Just out of curiosity, in case some people have not used their apps, just by show of hands, how many favor yes, keep trying something new forevermore? Strong raise of hands. And then how many say, at some point you have to say enough is enough? So by hands it looks evenly split, but most people didn't vote.